Good morning. Welcome back to Open School. Today I am going to discuss with you about mitral stenosis. In the following few minutes, I will be discussing the etiology, the pathophysiology, major symptoms. The next session will discuss physical examination findings, how to assess the severity and timing of surgery. So here you can see the mitral valve, which prevents regurgitation of blood from left ventricle to left atrium during ventricular systole and allows passage of blood from left atrium to left ventricle. So this is the mitral valve, about which we have discussed in the previous session. Mitral stenosis is almost always rheumatic in origin. In the elderly, especially in the developed countries, it may be due to heavy calcification of the mitral valves, which usually produces mitral regurgitation. Rarely you can get a rare congenital parachute mitral valve. So the first cause of mitral stenosis is rheumatic, second is rheumatic, third is rheumatic. Next only comes congenital. Then it can occur in malignant carcinoid syndrome, drugs like methysergide, Whipple's disease, infective endocarditis, systemic lupus erythematosus. These are all rare causes. So if somebody asks you what is the cause, in almost always it is rheumatic. In the rheumatic mitral stenosis, the mitral valve orifice slowly gets narrowed. So this is the mitral valve orifice that gets narrowed. Due to fibrosis and calcification of the valve leaflets and fusion of the cusps and subvalvular apparatus, this leads on to impediment in the flow of blood from the left atrium to left ventricle. That is, flow is restricted. So when the flow is restricted, what happens? The pressure inside the left atrium increases. Normally, during ventricular diastole, the left ventricular pressure is around 5 millimeters. With the development of mitral stenosis, there will be development of a pressure gradient between left atrium and left ventricle during diastole. Consider that the pressure gradient is 20. Already there is a pressure of 5 millimeters, which is equalized with the left atrium during diastole. An additional 20 leads on to 20 plus 5, 25 millimeters of mercury. This rise in pressure in the left atrium is transmitted to the pulmonary veins, and this leads on to pulmonary venous hypertension. So now we can see that in the venous end of the capillary, pressure is increasing, the Starling force comes and fluid will translate into the atria. Fluid will transit into the lungs. It produces interstitial edema followed by pulmonary edema. The work of breathing increases. The receptors are activated, the J receptors. All this will lead on to feeling of breathlessness. In addition, there can be hypoxemia that can stimulate the chemoreceptors also. So the fundamental problem in mitral stenosis is development of a rise in left atrial pressure. The rise in left atrial pressure leads on to hypertrophy of left atrium, and the filling of left ventricle more and more depends upon the atrial contraction. That is the atrial kick. As the left atrium dilates, it will go into atrial fibrillation. So development of atrial fibrillation is a turning point in the natural history of mitral stenosis. A patient with a class 2 symptom will worsen to class 3 or class 4 with the development of atrial fibrillation. Now we'll think a little more into the pathophysiology. Suppose a patient with mitral stenosis develops tachycardia. This will lead on to reduction in the diastole, because if you take the cardiac cycle, approximately 0.8 seconds, 0.3 is systole and 0.5 is diastole. It is a diastole that cuts short. And as we know that the blood flow from left atrium to left ventricle occurs in the diastole. So diastole cutting short, what will happen? This will lead on to further increase in the pressure in the left atrium. So tachycardia, either due to exercise, fever, infections, or development of atrial fibrillation will lead on to worsening of symptoms. And that is why exercise and pregnancy are poorly tolerated in a patient with mitral stenosis. Coming to the etiology, we already said mitral stenosis is more common in the developing countries, and 2/3 of the patients are females. There is a female predominance. And 25% of the patients, it is only the mitral valve is affected. Around 40% mitral valve. In addition to mitral stenosis, not only isolated mitral stenosis, in addition there will be MR. So 25% you get isolated mitral stenosis. Around 40% you get a combination of mitral stenosis with mitral regurgitation. Around 40% mitral stenosis will have other valvular lesions, especially the aortic valve disease. So here you can see the mitral valve. So if the mitral valve becomes not only stenosis, there is incompetence. That is, incompetence means during ventricular systole, blood will enter the left atrium. Now we go into the symptoms and the size of the mitral valve. The normal mitral valve area is 4 to 6 cm square. In diastole, and may get reduced to 1 cm square or less with a severe mitral stenosis. Patient usually becomes symptomatic when the mitral valve area is less than 2 cm square. Initially, the symptoms occur only on exercise. In severe stenosis, left atrial pressure is permanently elevated, and so breathlessness occurs even at rest. And this is due to the chronic pulmonary venous congestion about which we have discussed. Mitral stenosis leads on to low cardiac output because the left ventricular filling is less. So this will lead on to fatigue. So the two major symptoms, breathlessness, fatigue and palpitation. As discussed, the normal mitral valve area is 4 to 6 cm square. In severe mitral stenosis, the area is less than 1 cm. In moderate stenosis, it is approximately 1 to 1.5 cm. And in mild stenosis, 1.5 to 2.5 cm. And minimal symptoms occurs when the size becomes less than 2 cm square. And with the moderate stenosis, you get symptoms at rest. And we have discussed the major pathophysiology. Mitral stenosis leads on to diminution of mitral valve area. This leads on to increase in the LA pressure, and there is development of a pressure gradients. Elevated left atrial pressure leads on to pulmonary venous hypertension. This further later leads on to pulmonary arterial hypertension. That is, pulmonary venous hypertension leads on to arterial hypertension. Pulmonary arterial hypertension leads on to secondary right heart dysfunction, leads on to right ventricular hypertrophy, later right ventricular dysfunction, right heart failure, tricuspid regurgitation. And the elevated left atrial pressure leads on to left atrial enlargement, leading on to atrial fibrillation, development of LA thrombus and risk of thromboembolism. So we have discussed the pathophysiology of mitral stenosis and etiology, and the major symptoms: dyspnea, palpitation, fatigue. Sometimes you can get hemoptysis, recurrent bronchitis can occur. The enlarged left atrium may compress on the esophagus. So patient can come with dysphagia. It may compress the recurrent nerve, leading on to what is called the alternate syndrome. The patient can have hoarseness of voice. In the next session, we'll be discussing the physical examination findings.